Oh, dia tak ada. Oh, dia boleh. Boleh ya. Okay. Hmm. Okay. Saya copy dulu. Ya, boleh. Yang atas ni? Ah, bukan. Yang bawah ni. Oh, ni tak boleh apa macam tu. Tak ada lain. Tak ada lain ke? Dan tajuk sama kan? Tajuk sama ni. Nah, ni paling bawah ni. Nah. Mana ni? Bukanlah, saya buat yang ni dulu. Ah, okay. Masukkan ke tu je. Gambar tu je. Gambar untuk sebab tu. Boleh lah, tak apa lah. Tak letak pun tak apa. Dah ada letak lah. Dia ini kalau masa present tu I tekan apa? Ni. Seperti ni. Ini undur balik. Ini ke depan. Oh, saya tak boleh macam full screen kan ni? Sebab kita nak saya tak nak macam tak perlu tengok next slide. Saya terus tengok slide. Boleh macam tu boleh ke? Display saya tengok. Hai, good morning, Mr. Chang. I'm the MC. Hai, hello. Macam ni? Dia tanya. Macam ni. Dia tanya dulu. Dah. Saya setting je. Macam ni boleh? Ya, saya boleh. Macam ni. Macam ni boleh. Betul. Nah, kalau saya dia boleh guna ni lah kan? Boleh. Dia boleh tunjuk. Okay. Ini saya cabut. Boleh. Hello. Ini belum on ya.
Halo, halo.
Oke. So, okay lah. Oh, kalau di sini masih macam ni. Masih dia biasa sangat pada isi SPM sebab itu untuk project design di distrik is penting. Kalau sini nak cakap sekarang saya rasa dia memang perlu beli dia saya sini bila edit tu saya tulis nak buat tu satu tulisan sebab yang idea orang masuk di mau dia pada ada tengok siapa sorry, I forgot. So how do I go in? Sorry. I left the presentation slide already. How do I go in? So I tekan escape tadi. Tadi ni lah. Tekan leave. Sorry. Sorry. Macam mana nak tukar balik slide ni? Oh, sorry. Oh, okay. Saya nak scroll ke bawah saja boleh ke? Okay. Okay.
Yes. Ladies and gentlemen, we're about to begin shortly. Please be seated and ensure your mobile phones are in silent mode. For attendance, kindly scan the QR code displayed on screen using the attendance link via WhatsApp. For attendance, you can scan the QR code on the screen projected, or you can use the attendance link which we share via WhatsApp, which has been distributed by the person. For participants from district hospitals who join the ceremony online, any questions or welcome to the chat box on the YouTube channel. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good morning to our honorable guests, Dr. Anastaki bin Tutu Ahmad, our Deputy Hospital Director, Dr. Nurhana bin T. Muhammad Fazil, Deputy Hospital Director 3, heads of departments, specialists, medical officers, nurses, and the rest of our respected staffs. First and foremost, I want to thank you for coming here today to attend our study session this morning. I am Dr. Ahmad from Octa Department, and I will be here today. Without further ado, I will invite our pediatrician, Dr. Chong Kun Hao, to present today's CME with the topic Comfort for Kids, a guide to manage pain with heartfelt care. Kindly welcome.
Hello.
Hello. Hi. Good morning, everyone. Okay, thank you for taking your time to attend to our hospital CME. So today my topic is actually about comfort care for kids, a guide to manage pain with heartfelt care. So as my title said, actually my topic is more towards pain management in pediatric patients, but not so much into what medication we use, because I believe that a lot of us already very good in managing by using medications. But my purpose of this CME is more to raising awareness that how to approach when the patient has pain, the pediatric patient has pain, like how do we assess, what tools do we use, and what other non-pharmacological strategies that we can offer to manage the pain. So till date, actually, pain management in our settings is still suboptimal, I would say. A lot of kids actually presented to hospital with pain are still not properly managed. They are under treated and always under recognized. So hopefully by end of this CMB, everyone have a clearer idea and more confident and more sensitive toward pain for our pediatric patients. Okay, so yeah, let's begin. So in 2008, pain has, as a fifth pointer sign, has implemented in our KKM, and up till date, 2020, December 2020, there are 30 pain-free hospitals in our country, and I believe now we have more pain-free hospitals, and HRBZ is one of our pain-free hospitals in Kelantan. So this pain-free program actually started since 2001 in USA, and 2002 Australia, 2003 Europe, 2004 Singapore, and our country, the first pilot project is in Hospital Selayang in 2006. So 2008 onwards has officially implemented across the country. And the pain-free policy, I think this policy is stick around in all the corners around the hospitals. So I'm not sure all of us has actually gone through it, but this is the pain-free policy that we should know. So pain is one of the vital signs. Okay, pain is assessed in all of the patient. We need to standardize pain assessment tools and must be applied consistently. All the healthcare providers should always listen, respond promptly to patients' report of pain, and manage the pain appropriately. Healthcare facility staff should be continually educated and aware about pain assessment and management. So what is pain? So pain actually is very simple. Pain is just what the person says hurt. Okay, and by the definition from the IASP, the International Association for Study of Pain in 2020, is defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage. So a lot of myths actually surrounding for patients with pain, our pediatric patients with pain. So all of these are not true and is false. So baby do not feel any pain as the nervous system is immature, which is incorrect. Pain in infants and children is less than in adults. Infants have no memory of pain experience in early life. Children will get used to pain. Pain helps to build character in the child. Children's explanation of pain experiences is unreliable. Opioid analgesics are dangerous, and children may become addicted. So all of these are not true. But however, some of us actually still have this belief. So as a result of this belief, actually, pain in young infants and children have been traditionally under-recognized and hence poorly treated and managed. So as we can see in the pictures, even though the child has already an IV line inside too, with an IV drip there, and actually the patient still actually felt the pain, but how often that we think they actually are in pain. This drawing actually drawn by a child in Portugal around 6 years old. So about the evolution of pain management in pediatric patients, about 50 years ago in 1968, actually they reported as pediatric patients tolerate discomfort well and rarely need any pain medications. So actually pain wasn't an issue for pediatric patients back in 1960s. But however, later on, about 20 years later, it took 20 years for them to come up with a study that even fetus at 24th week of gestation, they have already have the perception of pain. And subsequently, this changed all the child pain management. So this was published in the New York Times in 1987. Infant actually has sense of pain and it is already recognized. So for now, recognizing pain in children is very important. But however, it's always undertreated and under-recognized even till now. So what is our current state of pediatric pain management in our country? So despite the advances of in understanding of pain in children, pain management among children presenting to hospital remains suboptimal. They are often given minimal and no analgesia for procedures or condition. The most common example is line setting, blood taking. How often do we offer them a analgesic? Okay, so even when the child given analgesia is often inadequate because all of us are very worried about the side effects. We are not confident. We are a bit phobia. Okay, so the younger the child, the less likely they will be given adequate analgesia. So all this is the current issues that are happening across our country. So what are the barriers that's stopping us? Okay, so there are a few factors. Okay, so the first and foremost, the most important factor is the child is often unable to communicate accurately. This is very true because they are children, they cannot report the pain like adults. Okay, so all they present to us is just crying, cranky, they are unable to localize, unable to tell how pain is a pain. Okay, so this actually hinder us. Okay, and the fear of side effects not only from the doctors, it's also from the parents. Okay, inexperienced doctor and not familiar with dosage. This is understandable because not all doctors actually are from pediatric field. Okay, and the choice of the analgesia that we know actually is quite limited at times. Okay, for example, just paracetamol. All right, and parents and children reluctant to report pain. This is true as well because sometimes the more they report, they worry that we might do more harm. Actually, we would actually offer more blood taking, line setting, and cause them to have more pain and miserable. Okay. So as the picture said, the child looks so much in pain, but why only TCM? But when we have so many other alternatives that we can offer. Okay. So what happens if we don't treat the pain properly or undertreat? Okay, they can have immediate effects, or they can have a long-term effect. So for immediate effects, okay, we can divide them to physiological and psychological. So for physiological, when they are in pain, automatically the heart rate will increase, blood pressure increase, okay, cardiac output also increase, and subsequently to increase oxygen consumption and reduce in the oxygen saturations. Okay, their blood sugar can be high because all the stress hormone has come out and lead to poor healing, poor growth and development, and disrupted sleep cycles. Okay, and for psychological wise, okay, they might develop anxiety, depression, anger, fear. Okay, and for long-term effects, okay, long-term effects, the most common example is a preterm baby, for example, a preterm baby, a 30-weeker, 1.5 kilo, or even lesser 1 kilo presented to our SCN and ICU requiring a lot of blood taking. If we don't offer a pain relief for them, okay, actually repetitive poking, breaking can cause them to have a long-term effect that they might become more sensitive and lower pain threshold that lead to their adulthood. Okay, so when they grow up, they will become more sensitive and lower threshold to pain, which we do not want this to happen actually. And other long-term effect, example, needle phobia, PTSD, and avoidant attitude to healthcare. This is also very, very common. We see a lot of child that presented to us haven't even stepped into the hospital, already started crying. When they see the doctor, they are so so forbid they hide behind their parents, refuse for us to examine them. So we do not want this to happen. So we need to start to manage pain properly in pediatric patients. Okay, as you can see from this picture, drawn by another 6-year-old boy from Portugal. Okay, we can see there's a huge scar, the midline sternostomy scar over the chest, multiple scars, another scar over the thigh, okay, multiple the chest leads, and also SpO2 probe, and also probably outline monitoring, okay, despite and also a nasal cannula. So with all this wiring and poking and everything, actually the child still appears happy if the pain is managed properly. Okay, so how do we approach for pain in children? So there's a mnemonic, okay, it's called ARAT approach, ARAT approach. So A stands for anticipate, always anticipate and prevent pain wherever possible. So if a child that comes to us, okay, need IV line or blood taking, always anticipate that this child might suffer from pain because of the painful procedure. So we can always offer like a local anesthetic cream, okay, even before the procedures, okay. Can also offer other non-pharmacological strategies before we proceed, okay. I will talk about it later. And then always recognize that child can feel and tell the pain, okay. If they telling you they are in pain, always take them seriously, okay. And then once you recognize that this patient has pain, assess them using the tools, okay, different tools we can use. I'll talk about it later with the ABCDE approach. And once we have identified, then we treat them. So this is the mnemonic for the pain assessment in children using the ABCDE. A, ask the child and assess the pain score. B, use the behavioral and biological measures. If the child is too young, less than 4 years old, they are unable to tell, they are non-verbalized, okay, we can use these biological measures and behavioral assessment, okay. So once identified, C, we find the cause, and D, and decide and deliver treatment in a timely manner, and E, evaluate the outcome. So A, ask the child and assess the pain score. So if the child is old enough, big child, nowadays they are very smart, okay? Even at 18 months old onwards, they can already tell you the child they are having pain. Okay, so you can always take a pain history from the child, okay? In the column there, I have put up, and you can read from there, and it's available from the KKM website. Always believe what they say, as every child is different. And if the child is unable or unwilling, we can always ask the caregiver or the parents. Okay, what about pain score? Okay, so pain score, actually there are different types of pain score according to age. Okay, there's no one size fits all. The one that we are most very familiar with the pain score of 0 to 10 actually is for bigger child like more than 7 years old. So what if the child is between 4 to 7, we can use a FACES revised pain scale from by the IASP. And if it's less than 4 years old, we can use biological measures, as I mentioned just now. So this is the revised FACES pain scale, suitable for 4 to 7 years old. So we show them this FACES pain scale, and we can talk to them. Okay. KKM website actually put up an English version and a Malay version. So for our Kelantan setting, I think using a Malay version is more appropriate. Okay, so we can tell them by pointing the faces over the left hand most. Okay, just say that muka-muka ini menunjukkan bagaimana sesuatu itu boleh menyakitkan. So point to the left hand most face. Muka ini menunjukkan tiada kesakitan. So as we point towards the right, okay, we can tell them muka-muka ini menunjukkan kesakitan yang makin lama makin banyak. Okay, then the right hand most with the score of 10, okay, ia menunjukkan kesakitan yang amat sangat. Okay, so sila tunjukkan pada muka yang menunjukkan betapa banyak kesakitan yang anda sedang alami sekarang. Okay, so 4 to 7 years old usually can tell you that. So what if the child is more than 7 years old? Then we use this skala kesakitan, okay, the numerical scale, okay, from 0 to 10. 0 is no pain, 10 is the worst pain ever experienced. Okay, ask the child to rate. So what if the child is less than 4 years old? Or what if they are infant or they are neonate? Okay, so we can use behavioral and biological measures. Okay, for example, FLACC, flag, and NIPS. Okay, just by looking at their clinical conditions and also from their facial expression, behaviors, and all. Okay, so this is for flag, FLACC. F stand for face, leaks, L stand for leaks, A stand for activities, C for cry, and C also for consolability. So each component have their own scoring. So refer to the component. They have the score of 0, 1, and 2. So we need to observe the patient and come up with the scoring. So the observation actually is very important. Preferably about 2 to 5 minutes. If the patient is sleeping, you might need to monitor or observe for more than 5 minutes. Okay, and you need to uncover the patient. Always observe the body and the limbs, okay, the legs. And you might need to reposition the patient if needed. If let's say the patient, sometimes they sleep in a prone position, they sleep in a lateral position. Okay, always reposition them so that you can observe fully and properly and assess their body for tenseness and tone. Okay. So the the pain score, if let's say you get a total score of 1 to 3 is mild pain, 4 to 6 is moderate pain, and 7 to 10 is severe pain. Okay, and for neonate, less than 1 month old, we can use NIPS. Okay, NIPS is called a neonatal infant pain scale. Okay, this is also somewhat similar to the flag assessment tool. It also looks at the behavioral and also the clinical condition. The components are facial expression, cry, breathing patterns, arms, legs, and state of arousal. So each component got their own scoring as well. So add up together, then we get the total score. And the score of 1 to 2 is mild pain, 3 to 4 is moderate pain, 5 to 7 is severe pain. Okay, just to recap, one month to 4 years, we use the flag scale. 4 to 7 years, use the revised phases. Okay, more than 7 years old, use the numerical rating scale, and less than 1 month, use the NIPS. Okay, once we have identified they have pain, we have already assessed, come up with the pain score, then next we need to find the cause. Okay, so before starting any treatment for pain, always consider the possible cause. Sometimes the cause is so trivial, it's so easy, it could just be a tissue IV line. Okay, sometimes the line is extravasated, the line is broke up. Okay, what we need to do is just remove the line and we don't even need medication to relieve the pain. Right? Or another example, if the patient, a post-op patient that come back with a bladder distension, urinary retention, probably just need to drain the bladder and the abdominal pain will subside. So these stand for decide and deliver treatment in a timely manner. Okay, so if the pain is present, always discuss with the child and caretaker, sometimes even before we approach them, they are already telling us that the child is in pain, they need medication. Okay, so we treat them seriously and give them, and of course, after our assessment. So intervention can be both pharmacological or non-pharmacological methods. And we need to evaluate the outcome after given the medications. Okay, so always go back to reassess the child. If you have already given the medication, if the child still in pain, you might need to add more medications. Okay, by going through the analgesic ladder. Okay, I'll talk about it later on. And what are the methods? Okay, so now we know how to assess, we know how to score the scoring, and we need to know what are the methods available. So I think a lot of us are very aware of our pharmacological methods, but what about non-pharmacological? Actually, they have a few things that we can practice and it's easily done. Okay. So the pharmacological management for pain, okay, focuses on controlling the physiological pathway of pain. But non-pharmacological methods are useful in reducing both physical and emotional aspect of pain, for example, anxiety and fear. Okay, so studies shown that actually 80 to 90% of children in hospital experience pain due to painful procedures. Okay, 80 to 90% of them have pain because the painful procedure, example, line setting, blood taking, okay, cause the 80 to 90% of them to have pain. Okay, so the painful procedures are actually defined as medical procedures that can cause a short-lived and acute pain. So different non-pharmacological intervention can be used to manage the acute pain. Okay, for example, preterm baby, neonate, or older infants. Okay, it's proven to reduce the amount of medication we need to treat the pain. So these are examples of painful procedures in our hospitals, okay, or in any clinic kesehatan settings: blood taking, vaccination, wound dressing, the heel prick for glucometer to check the glucose, and also lumbar punctures. So we can see when the child presented to us with this kind of hand, we will be very fearful. Okay, so not only the child will experience repetitive pain, and for us as a medical personnel also, we will feel very pain. So once we see this kind of patient, of course, we need to anticipate probably multiple line setting, multiple attempts. Okay, so always think of what can we do for them. Okay, we might want to offer them analgesic cream. Okay, and non-pharmacological approach and strategies can help. Okay, I'll talk about it later. Okay, the first and foremost, most important strategy is position of comfort. Okay, a lot of us actually, when the child presented to us, need to take blood set line. Okay, we take out the blanket, balloon restraint. Okay, 6 people holding the child in the treatment room, and the mother is standing outside listening to the child crying and screaming. So it's not comfortable for the parents. It's not comfortable for other parents who are there as well. And it's quite cruel. Someone is quite cruel. Okay, so the first rules is do not restrain the child during the painful procedures. Okay, they should be in place in a position of comfort, sometimes known as a hugging hold. Okay, this allows the parent to hold their child during the painful procedures. Okay, maximize the child's comfort, give the child a sense of control, especially if held upright. So a lot of them, the bigger child, they prefer to be sit up or even stand up. Okay, they want to be in the upright position. They want to be in control, rather than you put them lying down, with hold them and restrain them with the blanket. Okay, just like the same concept, like if your wife is driving, you're at the passenger seat, you wouldn't prefer to lie down and sleep, right? You always want to sit up and observe your wife. Okay, make sure she's driving safety and all. Okay, so also minimizes the child's movement, thus allow a safe and speedy procedure, provide the active role for the parents in supporting their child. This is a very good example, okay, what we should do. Okay, the presence of parents is very important to reassure, distract, and encourage and comfort the child. Okay, you see the mother is actually holding the child from the back, okay, and another person is distracting, using a distraction, and another person performing the procedures. This is called a back to front bear hug. Okay, good for bigger child who needs to be helped but wants to remain upright. Can use for bigger babies. Okay, good for IV line, blood taking, injection, NG tube, port access, and examination. Okay, another method, chest to chest bear hug. Okay, the patient chest is facing the mother chest. Okay, and the patient actually look away from the procedure. Okay, this is good because allow the children to turn their head away and not watch the procedure. Okay, the child renders the parents, okay, to feel more secure. Good for IV line, blood taking, injection as well. Okay, this frog hole, okay, seldom practiced but still effective sometimes. Okay, parents at the head and can provide distraction, good for bladder catheterization, pelvic examination, chest tube removal, or dressing. Okay, swaddling. Okay, so suitable for infants for 0 to 6 months. Okay, always adjunct with other methods. For example, non-nutritive sucking if the patient has a pacifier. Okay, can always offer the pacifier together with the swaddles. Okay, then can adjunct with the sucrose. Okay, I'll talk about oral sucrose later on. Leave out the limb for procedures, and after the procedure, okay, continue to swaddle and continue to comfort the child to facilitate recovery and calmness. Okay, so another non-pharmacological strategies, okay, distraction. Okay, I think everyone know how to distract their child using Cocomelon and Baby Shark. Okay, so it's proven very effective, up to 50% in reducing the pain and distress. Okay, reduce the procedural time and number of staff required. Okay, recommended in all age group. Okay, all child likes Baby Shark. Okay, and must be employed before the child is too distressed. So you start the distraction even before the child enter the procedure room. Okay, start turning on your phone gadgets with all the cartoons. Okay, during the procedure and after the procedure as well. Can be practiced by anyone and requires no training. These are other examples. Okay, you can use toys, okay, storybooks, okay, cartoons, stress balls, blowing bubbles if you have, and blowing spinners. Okay, but nowadays it's all about gadgets. So gadgets actually do everything. Okay, so we have finished about non-pharmacological. Now we go to pharmacological management of pain. So the key concept is always go with by the ladder. Okay, prescribe analgesic according to the analgesic ladder. Okay, by the clock, give the analgesic around the clock rather than just PRN basis. Okay, if the child is having pain, don't just give PRN basis. You need to give regular. Okay, TDS, QID, or 4-hourly. Okay, just to make sure there's a steady blood concentration. Give the least invasive route as possible. Okay, try to give oral if can. Okay, because we don't want to prick them, don't want to set a line or give an intramuscular, which actually can cause more pain to them. Okay, and by the child, every child is different and unique. Okay, need to tailor the medications according to their needs. Okay, individualized treatment. Okay, so this is the modified analgesic ladder for pediatrics. Okay, mild pain is 1 to 3, pain score 1 to 3. Can always consider just non-opioids is enough. PCM and NSAID. Okay, NSAID, for example, ibuprofen, diclofenac, naproxen is commonly used. And moderate pain, pain score 4 to 6. Okay, we can use non-opioids. Okay, together with opioids. So, for example, PCM, NSAID with opioids like tramadol. So if the pain is more severe, pain score 7 to 10, okay, we can use a strong opioid together with other non-opioids, PCM, NSAID, or sometimes can use adjuvants like amitriptyline, carbapenem, ketamine, or clonidine. Okay, so as I said just now, if we anticipate the child need a line setting, okay, blood taking, can always consider this local analgesic cream. Okay, it's called EMLA. Okay, I think EMLA is easily available in our pediatric ward. Actually, we have it lah. So I do recommend that if you are in clinic kesihatan or if you are at ED or ped surgical ward, so I think you probably need this. Okay, so maybe you can discuss with your pharmacist and see whether you can have a few EMLAs to stand by in your ward. Okay, so for EMLA, it take times to work. Okay, so it's once you have applied, then you need to wait about 30 to 60 minutes before you can start breaking the patient. But before you apply the EMLA, always assess and identify the vein first. Okay, because once you apply EMLA, sometimes it can cause some local reaction, some redness, and also some blanching. Okay, so after you wipe off the cream, you might not see the vein as clearly as before. Okay, so make sure you always assess, identify first, put on the cream, cover with Tegaderm, then wait for 30 minutes or 60 minutes before you start the procedure. Okay, but be cautious, always make sure the skin is intact. Do not apply on any wound or any lacerated skin. Okay. And for infants less than 3 months and with G6PD deficiency, there's a higher risk of methemoglobinemia. So try to avoid that. Okay, another local anesthetic is called ethyl chloride spray. This spray is also very useful. Okay, the difference between EMLA and ethyl chloride spray is ethyl chloride spray works immediately. Okay, once you have the spray, okay, you spray for about 4 to 10 seconds, about 10 to 20 cm from the skin, and then you need to immediately proceed with the procedure because the numbing effects only last for a few seconds. Okay, but sometimes some people do not prefer this because sometimes the child perceive the numbness effect as pain. Okay, so they might not like it. Okay, but of course, in emergency setting, if the child is sick, very ill, in shock, you need a immediate resuscitation. You probably this probably won't work lah. Okay, because it takes time for you to do the line setting. Okay, for the effect to work. So other medications, paracetamol, I think everyone is very familiar about paracetamol, but however is the most commonly used and very excellent drugs to use. Okay, excellent safety profile. Okay, lacks of significant side effects, can give oral, IV, or even rectum. Okay, suitable for mild to moderate pain, acute and chronic pain. So if the pain is more severe, severe to moderate pain, we can adjunct with other medication, for example, NSAID. Okay, can even adjunct with paracetamol and can adjunct with opioid as well, like for example, tramadol. Okay. So do you know that actually paracetamol takes time, almost about 2 hours to work? Okay, so if let's say you want to do some painful procedures, you probably need to give the medication earlier, even before you start your procedures, okay? But do not use on a regular basis for more than 48 hours without medical review, because even within the therapeutic dosage can actually still cause hepatotoxicity. So if let's say you need to use longer than 48 hours, always make sure the liver function test is monitored. Okay, so now we talk about NSAIDs. Okay, NSAIDs is very effective for mild to moderate pain, especially in inflammatory pain, for example, arthritis, soft tissue injury. Okay, combined with paracetamol is very effective. Okay, but the risk is GIT bleed, renal impairment, platelet dysfunction. Okay, contraindication in coagulopathy, peptic ulcer disease, and renal impairment. Okay, be very cautious in a very young child. We do not usually give them if less than 3 to 6 months. So for NSAID, the most commonly used is ibuprofen for us, from us. So less than 3 months, we don't recommend the use of NSAID. Okay, for more than 3 months, can use up to 5 per kilo TDS to QID. Okay, if it's 6 months and above, okay, we can consider higher dose, 5 to 10 per kilo TDS to QID. Okay, so we can also consider diclofenac suppository, okay, commonly used for post-op patients. Okay, rectally can use 3 mg per kg per day in 2 to 3 divided dosage. Okay, so next we come to opioids. Okay, opioids, for example, morphine, fentanyl, okay, is very useful for treatment of pain in all patients. So for moderate to severe pain, okay, we always use the morphine, okay, and if possible, avoid IM injection because you don't want to cause further pain to them. And weak opioids is quite useful, okay, for mild pain to moderate pain, tramadol, and stronger opioids like morphine and fentanyl for severe pain. So I'll talk about morphine here, okay. Morphine indicated for procedures like post-op pain and burns, oncology patients, and other painful conditions, for example, acute pancreatitis, acute abdomen, or digital ischemia. Their side effects can be quite significant, so we need to have proper monitoring. For example, respiratory depression, nausea, vomiting, okay, and contraindicated for patients with history of apnea, airway obstruction, head injury, raised intracranial pressure. Okay, so the dosing for 1 to 12 months is about 0.1 per kilo, up to 4 times a day. If it's more than 1 year old, can give more frequent, up to 6 times a day, 0.1 per kilo. A little bit on ketamine. Okay, so ketamine actually is useful, very useful, but need to be given by a trained personnel, a trained and experienced personnel. Okay, usually it's useful for sedation and also analgesic because ketamine has two properties, can sedate and give analgesic at the same time. Okay, but the side effects increase the secretion. Some people prefer to give atropine before the ketamine, and the analgesic dose is 0.2 to 0.5 per kilo, and for sedation is about 1 to 1.5, even sometimes up to 2 per kilo also can. Okay, so about neonatal pain. So I mentioned about neonatal pain score. We can use the NIP score. Okay, once we have the NIP score ready, okay, we know whether the neonate is in mild pain, moderate pain, or severe pain. So if the patient is in mild pain, use the non-pharmacological strategies like wrap them, swallow them. Okay, can give them breastfeeding. Okay, or give them a pacifier and offer oral sucrose. If the pain is moderate, can consider oral and IV PCM. Okay, if the pain is severe, can consider IV opioids like morphine. Okay, so oral sucrose, okay, is also very useful. So I think if KK or is ED actually can probably benefit by using oral sucrose. It actually works well for infant less than 12 months, sometimes up to 18 months. Okay, suitable for premature babies or term babies. Okay, so when do we use? We can use if you want to do minor procedures, for example, a blood taking, line setting, okay, or dressing or remove the ECG leads because it can be very painful. So other procedures like laser, ROP examination, chest drain insertion can be used as well, but need to adjunct with other analgesic. Okay, so be cautious because the oral sucrose actually work for about 5 minutes only. So make sure it's not a long, painful procedures. Probably just single attempt of painful procedures is good enough. Okay. And contraindication is those patient with sucrose intolerance, and make sure the patient can swallow, because this requires the baby to swallow. Okay, and if let's say the patient got swallow difficulty or impaired gut reflex, probably we need to hold it. Okay, so as we can see from the pictures, okay, the baby is swaddled, okay, comfortable, and then at the same time offer pacifier. If the patient is not on pacifier, you can ask the mother to breastfeed. Okay, at the same time also can offer the oral sucrose. Okay, this combination actually works quite well. Okay, and the dose and how to administer is we can find it from the KKM website. Okay, so I think that's bring the end of my presentations. I like this quote from Dr. Samuel Johnson. He said that those who do not feel pain seldom think that it is felt, because the patient came to you with so much pain, but however we don't feel their pain, we always tend to undertreat and under-recognize them. So I hope by end of this CME, everyone can be more sensitive toward our pediatric patients, okay? Because every pediatric patients is unique, okay? We should take time, sit down and really look at them, okay? Talk to the parents, okay? Look at the child, okay? Use the pain scores, okay? The tools, different tools that we have, okay? Assess properly, and then offer non-pharmacological strategies, okay? And then if needed, can combine with the pharmacological treatment as well, okay? So hopefully by end of this CME today, everyone is more confident and has more awareness towards pain management in children. Okay, thank you.
Thank you very much, Dr. Shah, for the very meaningful presentation. Now, we have opened the floor to all questions. Questions? If I may ask a question, Dr. Shah, regarding the oral sucrose, how does it work? Does it work by, is there any physiological explanation to the oral sucrose? Does it work just by distracting the child?
No, actually, it's not distracting the child. The oral sucrose actually promotes the release of some hormones, actually to reduce the pain, okay, to reduce the sensitiveness of the pain receptors. Okay, so it's not actually to distract. Okay, so it's different from, I know last time back in district, we always use like the gauze soap with D10, okay, to give the child for comfort. Actually, that's not correct. So oral sucrose actually works by promoting some release of hormones, okay, and then to reduce the sensitiveness of the pain receptors. Okay, yeah.
So it has to be sucrose. If you use D10, which is not
No.
very
No, cannot. Okay, so it must be sucrose. So I recommend all of you to actually counter check with pharmacies, okay, whether it's available or not. If you have, I think better to have a few to stand by in the wards, okay, because it can be quite useful. Okay, we don't want the young babies to develop low threshold of pain in future.
Thank you.
Right, sure.
Anyone else have any questions? If there are no questions, I will invite Dr. Anis Fatih to deliver the certificate of appreciation to our respected presenter today. Okay, everyone, with that, we've come to the end of the session. The next session will be presented by the ophthalmic department with the same topic, myopia and retinal detachment, connecting the dots for better patient care. Thank you, everyone. Assalamualaikum. Yeah,